Right, ladies and gentlemen, moving on to the next one. So initially we missed a session of 20 to 40 age group session. So we're going to be taking that now, post which we're breaking for the lunch. Breaking the silence, healthcare challenges of the 20 to 40 age group, where the experts will look at the most common disorders of women which are not discussed but affect a large population of young women. Ladies and gentlemen, now I would like to invite the panelists on the stage. We have Dr. Chandrika Anand, Director PCOS Center and Chief Consultant Fortis Hospital. Dr. Chandrika Anand is a committed PCOS educator and has designed a unique integrated PCOS program for the community. Ladies and gentlemen, Dr. Chandrika Anand. Next, I would like to invite Dr. B. Oha Sushmita, neuropsychiatrist with Allo Health. With Allo Health and a mental health educator and an advocate. Dr. Sushmita works with patients facing various psychiatric challenges. A huge round of applause for Dr. B. Oha Sushmita. Next, I would like to invite on stage Ms. Atika Singh, a sexuality and menstrual health educator and building community at Allo Health, Young Person of the Year 2021 SHA, and a World Economic Forum Global Shaper. A huge round of applause for her as well. And I would like to invite on stage our moderator, Ms. Anu Bhatnagar, everyone. A huge round of applause for her as well. 20 minutes. Yeah.
Thank you. I'm just going to go straight into it because I'm already told I have 20 minutes. But the thing is, we have lots of important information which I'm going to ask the speaker. So please bear with us for a few minutes. There are just three sentences I'm going to read out and then pass on the mics to Dr. Chandrika. So World Health Organization suggests that endometriosis affects roughly 10% of reproductive age women and girls globally. That is roughly 190 million girls and women. The prevalence rate of PCOS is very high among Indian women. And the topics of sexual health are almost never discussed, be it homes, offices, of course, never, and even schools and colleges, which are almost considered the organizations and institutions which are going to equip us with life skills. So we are talking of lots of gaps. And I'm going to ask my first question to Dr. Chandrika, please. Please tell us, in your experience, what are the challenges women and girls in the age group of 20 to 40 feeling, and what are they coming up with? What are the problems and the gaps? And how do you suggest technology can help bridge the gaps? Thank you.
Yeah, this is a 1 hour topic actually.
Yes.
So basically the PCOS, endometriosis and vaginismus, these are the three topics, specific topics given today. But then let us look at these things or these issues are under addressed, and they are quite a number, in the sense endometriosis is around 4% in India. PCOS is around almost 10 to 20% in India, 20% of adolescents and 10% in reproductive age group. And then vaginismus, again, is under-addressed and under-reported. Now, what these three conditions how they can affect all of us. So, one thing, it can affect at the individual level. So, that girl who is suffering from endometriosis, there is pain, and there is suffering, there is heavy bleeding, PCOS, all those things. So, one is the individual suffering and individual complications. For example, a girl with PCOS, she is having pimples or unwanted hair. So, like, she is suffering in her own way. So that is one thing, so individual suffering. And what are the implications on the people around it or to the society? So women with endometriosis have got problems of sexual health problems, they have dyspareunia or painful sex. Women with PCOS can have infertility, that is a leading cause of infertility in women. Endometriosis contributes to infertility, And women with endometriosis may have to undergo surgery many times. And PCOS girls have to spend a lot on medications. And vaginismus, again, there are a lot of marital problems. So these three issues affects at the individual level, affects at the family level or the society level. And what about the policy making or the healthcare cost? Okay, women with endometriosis, as there are a lot of women workforce at working places, because of the severe pain and dysmenorrhea, they can't do the work properly, their efficiency comes down. Women with PCOS have got a high incidence of anxiety and depression, their quality of life comes down, their contribution to work comes down. So overall, if you look at these conditions, it not only affects the individual, it affects the family, the society, the government, the workplace, because a lot of money has to be spent. In the US, $20 billion are spent on the PCOS. So there is a huge impact, and all the three are increasing in its prevalence. It's not like, it's coming down or it is something. This is what we studied 20 years back or 30 years back. Compared to that, then it is increasing. So these are all very relevant topics of discussion.
In your experience, what are the gaps that you feel right now a patient is facing, other than help of a doctor like you? And how the technology can really fill in those gaps? What do you want the femtech entrepreneurs here to solve for you?
See, it's indeed exciting to see that so many technology people are here and they want to really help out. Now the prevalence, I'll talk more about PCOS because that is my research topic. We do have research in my center. And also it includes endometriosis kind of. See here, the disease is so enormous. Imagine 10 to 20% of women around us are suffering from PCOS. How do we expect all these women to know that they have PCOS? So one thing is there has to be something to create awareness among the general public in local languages to know that, okay, now you could be having PCOS. And you could be having, so you don't have PCOS. So women, now because of the so much of information on the media, everyone thinks that, little bit, one day they are feeling little low, so they'll go for therapy. They are not depressed. So there has to be a scientific evidence-based predictive model which you guys can build. Take 1 lakh people with PCOS, check out what are their commonest symptoms. Check out what are their least common symptoms, make an algorithm, create an app, so make a questionnaire. Do you have PCOS? In the local languages also. Because this has to reach to the villages. We are not worried about urban. Urban will come to us anyways. So villages, because everyone has an app, everyone has an Instagram, so they will see. So do you have PCOS? Give them 10 simple questions. So they'll answer. Okay, now if you have answered more than 7 yes, you could be having, so go to the doctor. So that is first thing. There is a predictive modeling you can do. Next thing is preventive modeling. So now a lot of women sitting in the rural area may not have an access to gynecologist or any other cosmetic dermatologist, because PCOS is a condition or endometriosis is a condition where even vaginismus for that matter, which involves multiple doctors. A gynecologist, a dermatologist, cosmetologist, psychologist, psychiatrist, dietitian, exercise, yoga, there are so many things. So every individual can't go to all the doctors at once. So you can create a preventive model. See, I don't want all the patients of PCOS in Bangalore to come to me. I don't have so much time. Because just now people were asking that the radiologist has to inquire about how the patient is feeling. Do we have time? I have, because it is my center, PCOS center, one of its kind in the world, because I have all these people in my clinic and I have my assistants and research associates. They will take the interview. I have trained the nurses to take an interview of 20 minutes. Who will spend 20 minutes, which gynecologist will spend 20 minutes with a girl who has come with pimples or unwanted hair? Because we need to address all the aspects. It is impossible for the doctors to address all the aspects of PCOS or endometriosis every day. Unless we are, otherwise we have to charge one person 2,000, 3,000. Is that the point? That's not the point. We need to go to rural. So actually what is the main treatment of PCOS is lifestyle modification. You have to lose 5 to 10% of your body weight. 100 kgs, lose 5 kgs. 50 kgs, lose 2.5 kgs. Easy, isn't it? We can't tell 100 kg woman to lose 30 kgs and come back. She'll never come back to you because it's impractical. So we have to give them specific goals, smart goals we call, specific, measurable. You know, we'll tell you measure your abdomen circumference. That abdomen circumference fat is a bad fat. Okay, so measure that. So measure after 2 months. So she can upload that. So you know, so that it has to be a specific goal, it has to be a smart goal, it has to be an achievable goal. As I told you, now, like, you know, in 1 month lose 10 kgs and come back, she can't do it. She will leave your app. So it has to be achievable, it has to be measurable, it has to be specific, and it has to be reasonable, you know. And also it is a time bound. I won't tell lose 10 kgs in 2 years. It has to be a time bomb. So all these things you can create. So we can actually bypass going to the doctor. So do you have PCOS? 10 questions. Okay, if you are answering yes for 8 questions, start exercising, start dieting. Okay, you know, so that you kind of bypass them because the workload is so much. We can't treat all the PCOS girls in Karnataka, or it is very, very difficult. So the load is so much and it is increasing day by day. So this is where I feel the apps are very important. And even our international society guidelines, PCOS society guidelines, they have told use apps, use that tracker, step tracker, use apps. We want you to use anything, lose weight. Our goal is to lose weight. So your AI and your apps or your technology can come in prediction, it can come in prevention, but also to screen. Suppose you are having PCOS, please get these blood tests done. No, I can't tell and scream to the public that, you know, you get thyroid done, you get prolactin done. Your apps can do it. Okay, and if they find anything abnormal, then you go to a doctor. Because the final thing, as senior madam is telling, final thing is a human touch. So everyone comes with a package. So this PCOS girl who is having a hirsutism or unwanted hair, she is finding suicidal thoughts. So I can't just give her some tablets. So that final decision making is the clinician. So you can, all the tech apps we need the apps. We need the apps. And when you are designing an app, please use experts' advice. You can't take the internet or the text knowledge to design an app. Use take the help of the healthcare professionals. Involve them in designing the app. That is when it can be more practical and more effective.
Thank you. Yes, that's very important points. So I'm hoping somebody is making notes of all these points, because I cannot, I'm sitting here. Thank you so much, doctor. I'm going to come to you, Dr. Sushmita, and please tell us that what are the sexual health challenges for the women who are not able to find help anywhere except coming to you, and for various reasons are not able to come to you because of affordability, accessibility, or any other kind of a limitation. Thank you.
I'm actually very happy for the women who are able to come to me, because I think they're already taking, the right step in the right direction. So my concern would be more for the patients who are unable to reach out to me because of all the factors that you've just mentioned. A lot of women in India, maybe because of our cultural, setbacks and the way we speak about sex in general, for women there is not yet a language developed to talk about sex. So let's say a 26-year-old gets married, and on the first time having sex with her husband, she experiences pain. Most of the time she will rationalize it by saying, this is bound to happen. This is what my mother experienced. This is what my grandmother experienced. This is what all my friends are experiencing. But the fact remains that you're not supposed to feel pain during sex. That is not to be rationalized. That is when you are supposed to reach out to a professional and say, why am I having pain? You wouldn't rationalize a pain in your chest. You wouldn't rationalize a pain in your knee. Why are you rationalizing pain during sex? Because it has been told to us that it's normal, right? So a lot of this language is as yet developing. In one way, I'm very glad that we are talking about it in forums like this, because all the women who are sitting here, you're receiving some language. You're hearing words being spoken that you can translate and apply to your own life, and then you can translate when you actually reach out for help, right? A lot of my patients who do end up coming to me, I think among my patients, maybe 20% are women, And in those 20%, the majority come to me along with their husband, because a lot of the problems did start after they got married and are introduced to sex. And a lot of them do have something called vaginismus, which is why there might be pain, the pain during sex that I talked about. And when I ask these women questions, so have you ever had a penetrative experience? Have you ever gone to a gynec? Most of them have never been to a gynec. They've never gone for a general checkup. Have you ever masturbated? They've never masturbated. Have you ever explored your sexuality by yourself at all? In the urban population, I'm happy to say at least 3 to 4% say yes, I have. I've tried different things. But a lot of the population who comes from the more tier 2, tier 3 cities, they have never. This is their first experience. And their first experience is, I think, for the lack of a better word, I will call it brutal, that they do develop a problem for the rest of their life, where they experience pain throughout their life, they have vaginismus throughout their life, and they develop a lack of desire. And then the husband comes to me and says, my wife doesn't want to have sex. I'm like, why would she want to have sex? She's not having fun. She's not getting anything out of it. So why would she want to have sex, right? So this conversation, I feel, needs to happen before any marriage takes place, before you get into a relationship. And this is something that needs to be talked about to teenagers in schools, in, during their +1, +2, in 11th, 12th grade, which is when women start exploring their sexuality. And this is the major gap that I see when I see my clients. So major, I think, 2 things that I treat in women: no desire, vaginismus. These are the 2 things that I keep treating women for. And unfortunately, they are difficult conditions to treat, because we are not treating the body per se, but we are treating the mismatch between your brain, your perceptions about sex, and how you want your body to respond to sex, how you want your body to perceive sex. So that mismatch can become quite difficult to treat. And talking about it more and more, putting words to this problem, giving that language, putting that language out there, I think is the need of the hour.
Thank you, and very, very powerful words indeed there. I want to actually come to you, Atika. You are one of the finest community health educator, and taking what Dr. Sushmita just said, the need of awareness and education. And I guess this is awareness need not, for some reason when most of the campaigns happen, or even public health ads, they're always targeted at women. I'm yet to see a campaign which is solely focused on boys and men. As it becomes your yet another pressure on you to educate people around you. So how do you see that we could have awareness and education on the topics in a society like India, where probably girls are not even talking to their mother about it?
Absolutely. Thank you so much for the question. Just to kind of start this off, I am a public health anthropologist, and I remember being in college, and it was a class of 30 people, and there was just one boy. So in general, I felt like they were just not interested. I don't know what the reason was, honestly, but just coming from there. Definitely, like Dr. Ruha also highlighted, sexuality and sex and pleasure, in addition to that, is extremely tabooed in India. Before I moved to Bangalore, I used to work in Delhi, and I used to work with government schools in Delhi. And we had permission from the Directorate of Education, which is like the highest possible permission I could have gotten in Delhi. And despite all of that, and despite having the paperwork, we would reach the schools, and the teachers would say, okay, all the boys can go out and play. So our sessions were designed very much, they were very age-appropriate sexuality education sessions where, obviously under the age of 10 years old, we were only talking about consent and anatomy. But there was just this innate fear, even amongst the teachers, who would, very politely escort the boys out, because that was something they thought only the girls should know about, because somehow the responsibility of protecting against assault or protecting against violence is very sadly still on the women. And the reason that there's like a communication gap is because of that responsibility, because if someone goes through an incidence of abuse, at whatever level and at whatever degree, they feel embarrassed to even share it with their peers or their parents because they feel that they will be blamed for it. So I think we're looking at a systemic change, and definitely coming back to of course what I do, and I was very happy to hear Dr. Aruna talk about how there's just a gap in data and epidemiology, and that's something we work on at ALO as well, that we have no idea what we're educating for. You know, it's great to say that yes, we're educating and everything, but we have no idea what to educate for. So recently ALO ran a survey, and across 2 years we've surveyed about 40,000 people across genders and age groups. And we found some bizarre information, and I'm so sad to share it with this group, but one of the information was that 60% people said that if they had a disease/disorder, they would use Google or ChatGPT instead of going to the doctor, which actually puts everybody in the room at a very precarious position, because they've used their ChatGPT, etc., probably worsen the situation and then come to the doctor. They will come to the doctor eventually. So I think it's very important for me to have that data set to build even educational models. Luckily, there is a lot of effort that is being put into it. I've personally worked on a bunch of funded projects, which, everyone in my team was very surprised that we got funded to run an educational model. So I think education is, I wouldn't say it's an end goal. I think it's the start point of a lot of the things that can happen in the future. Education is what I feel like can inform conversations amongst parents. I run special groups just for parents to talk to young children, or just for children to be able to talk to peers. But it all definitely begins with some basic level of education around, in my case, of course, sex and sexuality and pleasure, but in general across different healthcare segments. That there needs to be some level of education to the parent or to the child. I've had children bring in their moms to our sessions, which was really nice to see for me. But yeah, I think if we can just start off with basic education for some key stakeholders, which includes teachers, in my opinion, teachers, healthcare workers, and parents, that would be a great place to kind of touch on.
Thank you very much. Do you have any, I'm going to ask you the same question. What you want the tech to do to sort of spread this awareness and somehow bridge this gap, especially for all the extra sensitive information? Dr. Uha.
I think from the technological side, I would want what I would call something sort of a SOS button. There are, like we just talked about, there are still a lot of women who are unable to reach out because they don't know what to reach out for, or even that they have a problem. But there is always that something inside that, why is my partner enjoying an activity so much that I have absolutely zero interest in, or I have very little interest in, right? So I feel if there is something like an SOS button where they can just reach out from the privacy of their home, from the privacy of even their washroom, and just ask a few questions, that will lead them to understand that, okay, this might be a problem, number one, and number two, that there is a solution to this if you only reach out to the right people or the right place, right? I think that is what might be required for women in particular, especially in the sexual dysfunction aspect of life. The other thing I would say is, again, coming back to the education aspect, because I think we haven't moved on. India as such, we are still in the awareness and education stage of sexual wellness. So coming back to that, I think there needs to be a lot more information out there from authenticated sources, instead of all the misconceptions such as women don't have orgasms, or masturbation is very bad for health and all of that. We need good information from good authenticated sources in regional languages, again, so that everybody in every corner of the country is able to educate themselves at least before their first night.
Thank you very much. I'm going to take one audience question if we have. Yes, please. I'll get you the mic. Thank you, Mr. Reddy.
Thank you. this is less of a question, more of a comment, right? So we spoke about how education is required and, you know, how rural is so much behind urban. But I just have a comment, right? I've been going to a gynax for maybe 20 years now. And my most recent visit was maybe 6 months ago. And Cloud9's, Apollo's, Fortises of the world, when you're registering for the gynax office, they ask you, are you married? And what does marriage have to do with sex, really, right? So, I mean, I'm sorry, I'm trying not to be disrespectful, but I think maybe that's a change we need to make, right? It's okay to say, are you sexually active? Instead of saying, are you married, right?
But most of the hospitals will have that.
No. See,
column.
there are a lot of women who get upset, unmarried girls who come to us, who get upset when someone addresses them Mrs. Pushpa, Mrs. Suma. Everyone wants to, they are very particular that they have to be addressed as Miss Sushma or Miss Suma, whatever. And at the reception level, they can't be asking about the sexual active things, so leave it. So when they come to us, we are okay whether they are married or unmarried, whether they are sexually active or not. Because most of us have evolved, you know, before 20 years back practice was different. So unmarried means we will never think of pregnancy and go on, okay, pain this. But nowadays we are okay with it, we have grown up, we have become non-judgmental. So there are people are advertising non-judgmental gynecologists. Okay, fine. We don't have time to judge. Okay, it just opens up a perspective. You are sexually active, yes, fine. That means, okay, now your symptom could be ectopic pregnancy, or it can be pregnancy, or it can be abortion. So it opens up a different, maybe some 5 to 10 new diagnoses. So we don't want to miss that. And that thing that whether you are married or unmarried, and also suppose there is an unmarried woman with a pregnancy, so obviously she may go mostly for a abortion or something rather than continuing the pregnancy. So that is a reason maybe. And also there are a lot of girls, as I told you, they get upset if we call Mrs. Suma, no, I'm not married, why are you calling them? Because these receptionists shout, Mrs. Suma, go there, then I'm Miss. So that's the reason, otherwise nothing else.
Just want to add to what you were saying. There's a Bangalore-based femtech startup. I won't name who. There are competitors. There are competitors, that's why. But I'm complimenting them. So they recently updated their website, and there was this one section which said, never get asked if you're married again. That was like their selling point. And, you know, pregnancy or not, I mean, being asked that, as a young person, being asked that is offensive sometimes. Like I'm already struggling with not being married. You don't have to remind me of it.
There's absolutely nothing personal in any of the questions we ask. We busy gynecologists, to be very honest. We are not really, before maybe 20 years back, there were unmarried girls who come with their parents who are already 5 months, 6 months, you know, they were rural girls and all that. That would be very exciting, and all these IMRs and nurses will ask, who did that and all those stuff. You know, like really, that was a story that time, maybe 25 years back. But nowadays we are very professional. We are not really bothered into it. Okay, now you bring your parents, okay, you are the legal age, okay, what to do next. So otherwise there is nothing personal about, you know, being asked any of the questions. Don't take it very personally.
Really? I think, okay.
Yeah. That's true. Yeah, they actually, if I just go with any man on the road, they will automatically call him like, oh, your wife is this and this and this. So you can't just fight everything. But on that point, I want to say that in your fantastic recommendation, I'm going to add that there is a need to have education and awareness for the medical community as well, who might not be so generous and non-judgmental as you, because it's a reality. Thank you so much.
I think it's an amazing topic that is being talked about now. I remember reading an article, I think in Deccan Chronicle or something a couple of years back, where people were compiling a list of non-judgmental OBGYNs, like ma'am said.
Yeah, there is one.
Yeah, exactly.
There is a registry of non-judgmental
Exactly.
doctors. And they are actually, in lots of feminist organizations, you can just literally get that list, so you don't have to ask unnecessary medical questions.
Which is
Unnecessary.
a very good thing, because I remember some horror stories from when I was doing my internship, and girls of 16 or 17 who pregnant, and they've come in for an abortion. They bring a random lady and call them, this is my mother, she's agreed, so please do my abortion, and then they would undergo Spanish interrogation just to get a simple process done.
No, absolutely. See, listen, you are not seeing the other part of it. I'm sure my colleagues will understand that. So there are this major couple, that is unmarried boy and a girl. They come with a pregnancy termination. This happened to my colleague, and then because they are major and the woman's signature is enough for the consent, and she either did the procedure or gave the tablets. And after 1 year, she got a police station called this doctor. So there is some issue with the boy and girl, whatever, I don't know whether they're getting married or not getting married. So the boy's parents, see now no one is bothered about what has happened. So they want to make use of the situation. So the boy's parents are alleging that the couple went for a pregnancy checkup and the doctor gave the tablets. So there are a lot of issues. We are very, very careful. And a minor girl comes to us and then we diagnose a sexual act or a pregnancy, we have to give the police complaint. We have to give, see, you know, the headache, I wouldn't even say the headache, it is our responsibility.
Yes,
the
of
legalities are so much. So when you say you are embarrassed or you are annoyed by the doctors asking so many questions, mind you, we are not really interested whether you are married or whether it is, seriously, I mean, when I see 60, 70 patients per day, I'm seriously not interested in who did that, where, what, how many, no, nothing. I just want to know, okay, now fine, you're married, or unmarried, okay, fine, you're active, okay, I'm going to rule out these things. So communication is the key. So please don't get offended. The doctors are busy and there are a lot of legal implications you wouldn't know of.
Thank you so much.
Just to put a
Sure,
cap on
yes,
it,
of
last
course.
comment, I promise. This, what ma'am said is very true. Defensive practice is the rule of the day. So that just brings up the requirement for a national data registry where we have all the patient details so that in case people come back after 1 year, after 2 years and try to leverage their own medical history against each other, we need to have those
It is
details.
a personal information. We can't share with the registrar.
No, but we need to have documentation and data registry.
We have a MTP register now, madam. We have it. All of us, we keep it. And we do give that to the family planning registry. We do that. So there is a fine line between confidentiality, comfort, expert involvement, and being non-judgmental at the same time protective. Say there are a lot of adjectives there. Absolutely. It's not easy. And you are dealing with that, you are not getting like 1 lakh rupees or something for that. It's a small procedure. It is a minor procedure. It's a very important procedure.
Understood. Yes, doctor. I think we will educate the community about this aspect as well and vice versa. Thank you so much. Please give a big round of applause for these wonderful doctors. Thank you.
Well, thank you so
Thank you for being a wonderful audience, and I guess now you all can proceed for lunch as well.
Yeah, thank you so much for panelists. It was really interesting topic though. Right, so we are breaking for lunch and I would request everyone to please be back by 2:15, okay? I would request everyone to please be back by 2:15. Thank you.